Welcome back, everyone. So our next talk will be from Priyanka. She is a physician assistant with the interventional group at MGHGI in the Swallowing, Heartburn, and Esophageal Disorders, or SHED program at Mass General. And she is obviously the co-director here for the APP session. So off to Priyanka.
Thank you, Alex. I appreciate the introduction. Again, it's wonderful to be here. And I'm actually presenting on inpatient and outpatient management of post-POP and POEM patients, which are most of my practice as an outpatient provider here at Mass General. So before I go into what POP is, what POEM is, what these type of procedures are, I sort of want to go through what basically each procedure is done for, the diagnosis for it. So what is gastroparesis? It's a disorder in which the stomach cannot empty food in the average way. So basically, it's taking a long time for this food to get through the digestive tract. It's characterized by waxing and waning symptoms of gastric or intestinal obstruction in the absence of a mechanical lesion. So what are some common symptoms of gastroparesis that most providers see in not only an outpatient practice, but maybe on an inpatient service too? So they may have some postprandial fullness, early satiety, where they just lose their appetite really quickly, even while they're eating, nausea and vomiting, which is one of the most common symptoms for gastroparesis, along with abdominal bloating, poor appetite because they'll get full really quickly or lose their appetite, weight loss, and sometimes even abdominal pain. So what are some causes of gastroparesis that we see here? Your number one most common cause is diabetes. Diabetes is commonly seen in most patients with gastroparesis, especially when they have poorly uncontrolled glucose levels. It's also seen in post-surgical conditions such as gastric bypass, a Whipple procedure, fundoplications. Again, the anatomy is a bit different compared to your average person, so it will affect the GI tract along with digestion of your food. Neurological conditions such as Parkinson's disease or muscular dystrophy. Those are some common causes, again, when the nervous system is affected, whether it's a condition, surgery, anything like that. It can also affect how the GI tract moves because there's so many nerves that do go to the GI tract to help with digestion too. And infections. Most commonly what we see or what I see is a post-viral infection where somebody has a gastroenteritis that already is affecting the GI tract, causing it maybe to slow down a little bit further. All right. So what is the management of gastroparesis? Before I go into at least all the management in regards to it, at least the POP procedure, I want to go over some other things that we most commonly see. So long-term treatment is guided towards nutrition. We want to make sure these patients have the ultimate nutrition. We don't want them to lose weight. We don't want them to get dehydrated. So basically following what we call a gastroparesis diet is important for these patients. That means eating small frequent meals, which Sarah Andrews has talked about very much in depth. Meals low in fiber, milk, fats, and gas-forming foods. You want to make sure that they're maintaining their hydration with lots of water and decaffeinated fluids. And especially if they have diabetes, we want to make sure that their blood glucose levels are in range or at least controlled. So usually less than 200, especially if they're eating, less than 100 if they're fasting, or a hemoglobin A1C less than 6.5. We also want to manage these patients with medications, which sometimes even a motility specialist may do also. So most common medications that I have seen, at least what some patients are on, Reglan is a very common one, erythromycin, and even some antiemetics such as Zofran and Compazine are common for patients. Again, we want to be careful with these medications because they do have side effects and they can affect the heart, such as QT prolongation, and also affect your nervous system too. And then lastly, when nutrition doesn't work or when medications are not really helping your patient, they're having worsening symptoms, we always want to think of endoscopic or even surgical treatments. Which brings me to the actual procedure that I'd like to talk about, which is the peroral pyloromyotomy, or what we call the POP procedure. It's a minimally invasive endoscopic procedure. It's used to treat appropriately selected patients with gastroparesis who do not respond to medical therapy. So again, they're taking Reglan, erythromycin, other medications, and it's just not working. They're having worsening symptoms. This procedure is effective for patients who experience nausea and vomiting as their main symptoms. So this procedure overall is to help improve symptoms, but not 100% cure it. So what is the POP procedure? I'd like to go a little bit more in depth with this because as APPs, we do see patients who go through POP and POEM. So the endoscope is advanced into the stomach to assess the pyloric sphincter. And it's used with a specially designed endoscope with tools right through it. And it tunnels through and the myotomy is made at the pyloric sphincter. So during this procedure, the muscle fibers are divided, and that's in the area where food is difficult to get through, as you can see in the image on the left side here. All right, so here's a short video in regards to how it's being done in real time. So we see here that an incision is being made into the mucosa. Dye is injected through this time, and the scope is actually being tunneled through right towards the pyloric sphincter. At this point, this is when your myotomy is made right into the pyloric sphincter from distal to proximal. Again, small cuts are made. We want to make sure that there's no complications from this, and this patient is being monitored the entire time. Again, that scope comes right through, and then there's closure with the clips. All right, so the important part here is a pre-op workup, especially for a POP patient. This is something that as an advanced practice provider, we want to make sure that we're going through it thoroughly with our patients before considering them for a POP. So obtaining a very detailed history is really important. We want to make sure, what are their symptoms? Are they having nausea and vomiting, bloating, loss of appetite, early fullness, or even satiety? And also their past medical history and past surgical history. Have they had, prior upper GI surgeries? Have they had stomach surgery? Have they had anything done within the bowel? Have they had ulcer disease? There's a lot of things within the past medical history and the surgical history that we want to make sure that we are aware of before considering them for POP. We also want to make sure that they have complete imaging and a workup prior to this. So a gastric emptying study that shows that they have gastroparesis and an upper GI series to make sure that we're ruling out anything physical that could be causing their symptoms as well. Again, we can also do an EGD with endoflip or an endoscopy with endoflip. And usually with that, there are findings consistent with pylorospasm that will help us determine even if the POP is going to be beneficial for these patients. And even prior to a procedure happening, we always want to make sure the patient expects what happens after the procedure. So that means following the diet before, at least 24 to 48 hours prior to the procedure, they're on liquids and they know what's happening. We also want to make sure that they know what the post-op diet is, which I'll definitely go more in depth with a little bit later. But at least with the post-op diet, we want to make sure that they know that they have to slowly advance their diet. Again, it's very important that we reiterate to the patient that the POP procedure is not a cure for gastroparesis. We always want to make sure that they know it's only to help to improve their symptoms and that they would need continued management as they go on. All right, so post-op management of patients in the inpatient side for POP patients. So this is something that we see very normally after a POP procedure because, again, it's a very high-risk procedure. We want to make sure patients are okay. So after the procedure, usually patients are admitted overnight for post-procedure monitoring. An upper GI series is performed the next day to ensure that there's no leakage at the site of the myotomy. So again, they're not eating or drinking anything after the procedure until this upper GI series is performed. Based on the reading, if there's no leakage, your diet is advanced to clears, and if patients are tolerating a clear liquid diet, then they can be advanced to full liquids prior to discharge. If they're tolerating the clear liquids, we want to make sure that they're started on a daily IV proton pump inhibitor post-procedure. Again, this is used to make sure that they decrease inflammation, decrease the risk of ulcers forming, and even strictures forming. If they're able to tolerate it, they can transition to an oral proton pump inhibitor daily. And during this time when they're inpatient, we always want to make sure that we follow aspiration precautions. We definitely don't want any heartburn, regurgitation, or any food or liquid that they're having to come up and aspirate and cause even complications of pneumonia at that point. So what happens when they're feeling well, they're able to take in full liquids, they're tolerating their medication? We see them as outpatient. We definitely don't want to stop following patients after a POP procedure. So in the outpatient setting, we follow up with them 1 to 2 weeks after the procedure. If there is improvement in their symptoms, so basically improvement in nausea, vomiting, bloating, early satiety, their diet is advanced to a soft diet. And they're also able to continue on an oral PPI for 4 weeks post-procedure. And I know Sarah went into depth about the soft diet, but a lot of the soft diet is something that we go through with patients very regularly in regards to what texture they should eat it at, how the bite sizes should be. They should chew it very well so it becomes really soft, and all that. If they have continued gastroparesis, so again, if they're having worsening nausea, vomiting, bloating, it's just not feeling well for them, we want to make sure that they stay on a full liquid diet or even go back down to a clear liquid diet. In this sort of sense, we want to make sure that we obtain a repeat upper GI series. We want to make sure we rule out any sort of complication that was not seen on their prior upper GI series when they were in the hospital. Again, we want to continue the use of neuromodulation with these patients because the POP procedure does not 100% cure this. We want to make sure that they're on medications, whether, again, it's their standard gastroparesis medications or even other medications that our motility specialists have followed, such as gabapentin. And again, we do have another talk later in regards to medication use for a lot of these patients. So, expectations of improvement. This is really important, and as I've mentioned multiple times, it's definitely something that we want to reiterate to our patients. So, patients may feel like they initially have improvement or even resolution of symptoms. They'll feel really great. They'll think, oh my goodness, this is amazing, 100% cured. I will never have this again. However, after a POP procedure, it is common that some of their symptoms may recur, but just not as much as it was prior to a procedure. So it is important to reiterate to these patients that the POP procedure doesn't cure gastroparesis 100%, and that we also may need to adjust these diets as the symptoms occur. So if they're having worsening symptoms, we always want to maybe back off to a clear liquid or a full liquid diet just to make sure that they're doing okay. And then once they improve a little bit better, we can always advance it again. So again, these patients always need continued follow-up, even in the outpatient setting, even with their primary GI if that's needed, or their whole healthcare team. So I want to go through a quick little case here in regards to the POP procedure. So I have a 56-year-old female with a history of obstructive sleep apnea, anxiety, depression, coronary artery disease. She had an NSTEMI in 2019. She also has heartburn and regurgitation. She has a history of peptic ulcer disease, and she had a partial gastrectomy in 2017. She came to clinic to be evaluated for nausea and chronic vomiting of partially digested food and bile. It was also noted that she had a history of multiple hospitalizations at different healthcare facilities within the past year, and she was also taking opioids for back pain for a long period of time. So along with the nausea and vomiting, she also had early satiety, bloating, abdominal pain, basically very common symptoms of gastroparesis. So what workup did she have? She had a gastric emptying study, which is abnormal. She had evidence of moderate gastroparesis with 30% gastric retention. And she also had an endoscopy, which showed residual food within the stomach. It looked like she had a recently healed peptic ulcer, and the mucosa of the partial gastrectomy was normal. It didn't look like there was any abnormalities or anything significant from that standpoint. So what are the next steps? Would you consider POP for this patient? So although there is evidence of gastroparesis, this patient shouldn't be considered for a POP because she does have a history of severe peptic ulcer disease, and she does have a history of a partial gastrectomy. Again, the anatomy is very different compared to your average patient. So the pylorus may not fully be there depending on the surgery that occurred. And also with peptic ulcer disease, this patient is at risk for, increased inflammation or even strictures in the area. So even with the procedure happening, we want to be very careful, especially with the history of peptic ulcer disease. I also want to note that this patient is on narcotics, which can limit healing and also worsen her current gastroparesis symptoms and slow that GI tract down further. So what would you do in this case? If she can't have a POP, what would you actually do? So in my perspective, since she is definitely on narcotics, I try to wean her off the narcotics and see what else we can do, and maybe try to do some medication adjustment and see if we can help improve her symptoms, especially since, the POP procedure would be difficult and shouldn't be considered for her. All right, so that was all entirely about POP. I want to go into our next procedure, which we usually see, which is the POEM. However, before we talk about POEM, I want to talk a little bit about achalasia, which I know we've had extensive discussion on earlier. So let's go ahead and do that. So achalasia, it's an idiopathic motility disorder characterized by loss of peristalsis in the distal 2/3 of the esophagus with impaired relaxation of the lower esophageal sphincter. And as you can see by the imaging on the right, through this study, you can see how tight that lower esophageal sphincter is, and also this backflow of barium in the image study. So what are some symptoms of achalasia? I know we've gone through this very much in depth, but I want to go through it again. There is difficulty in swallowing solid foods and liquids. And usually at that point, it's sometimes even a progressive dysphagia to even liquids. Patients may have substernal discomfort after oral intake. Regurgitation and heartburn are also very common symptoms where patients may even get that even throughout the night. They may cough up any oral intake or even aspirate on it, especially if they're having huge gulps of food or huge gulps of liquid. Weight loss is also something that can be seen with patients with achalasia, especially if they can't tolerate any foods or liquids at that point. And nocturnal symptoms. So again, these patients tend to cough up any sort of phlegm, even mucus at night, especially if they're laying down. They even have heartburn and regurgitation in the middle of the night that may wake them up and cause some discomfort in regards to that. So what are some things that we can do to manage achalasia besides the POEM procedure, which we've also talked about in depth? So we could do an endoscopically guided injection of Botox directly into the lower esophageal sphincter, which I know was talked about very much in depth before. It's not something that's commonly done unless depending on your patient and your clinical scenario of your patient. Pneumatic dilation, which Dr. Stoller went into great detail and gave us a really great talk about. As he said, it may require multiple sessions, so it's not a once and done procedure. It's something that the patient may have to go through even 2 or 3 times. Usually in this case, there are studies done where it's very less effective for patients that are less than 50 years old. And then usually with other types of treatments, and the one that I'm going to actually talk about is the POEM procedure, which is an endoscopic procedure. And then there's also surgical options such as the Heller myotomy. So what is the POEM, or the per-oral endoscopic myotomy procedure? It's a minimally invasive endoscopic procedure. It's used to treat patients with achalasia, type 1, type 2, and type 3. Most likely to respond to treatment is your type 2. It is an effective procedure for patients who experience difficulties in swallowing, substernal pain, choking and aspiration events, and heartburn and regurgitation. So what is the POEM procedure? As you can see by this image, there is a step-by-step process, sort of similar to POP, but actually in a way, it's actually looking at the lower esophageal sphincter. So an endoscope is advanced into the esophagus to the lower esophageal sphincter. On the first part, which is actually A in that image, an incision is made into the mucosa in the esophagus. On the B picture, the scope is tunneled through right towards the lower esophageal sphincter. And in picture C, an incision is being made right into the lower esophageal sphincter to open it up. And then once it's done, that scope comes back out through the same tunnel as created, and then there's closure with hemostatic clips in that area to close that incision. So again, pre-op workup is very important for POEM patients as well. We want to make sure that you're obtaining a very detailed history and physical. Again, what are their symptoms? What are they having difficulties of swallowing with? Do they have any painful swallowing with it? Do they have any heartburn, regurgitation? Are they losing weight? Has this been progressive, or are they only having dysphagia to solids only at this time? Additionally, we also want to make sure that they have thorough imaging and even an endoscopy workup. So again, a timed barium swallow is important. An esophageal manometry, which is mostly the gold standard for achalasia, and even an EGD with endoflip. And the EGD or the endoscopy can also help rule out other causes of the patient's symptoms and rule out even other maybe physical causes besides it too. We also want to make sure that we have the patient know what to expect long-term. So again, they have to be on long-term anti-reflux therapy after a procedure like this for at least 6 months. We want to make sure that the patient understands this. Just because of heartburn and regurgitation, we do not want to have inflammation in the area where treatment occurred. We want to make sure we decrease that risk and decrease the risk of stricturing and inflammation in that area. So pre-op management. This is also just as important for patients. We want them to understand, how to prep for a procedure like this. So the patient should maintain on liquids for, again, 24 to 48 hours pre-procedure. We definitely don't want any residual food or liquids within the tract prior to the scope going down. Again, based on timing, we always want to make sure that patients have optimal time where they're not eating or drinking, unless it's a medication that they want to take, or at least an important medication that they need, such as cardiac medications. In patients who have achalasia, they are at risk for candidiasis esophagitis too. So we always want to make sure that they're on empiric antifungals, such as diflucan, just to make sure that there's any decreased inflammation before we go down and treat this area. So post-op management. It's also very similar to POP patients, but again, sort of a different way. So for the inpatient management of POEM patients, they are definitely admitted overnight for post-procedure monitoring. Again, it's a high-risk procedure, so we want to make sure that they're closely monitored. Again, a barium swallow is performed the next day to make sure that there's no leakage at the site, nothing else abnormal after a procedure like this. If there's no leakage at the site, we want to make sure that their diet is advanced to clears and that they're monitored very closely. If they're able to tolerate it, then we can advance them to full liquids prior to discharge. If they are tolerating the full liquids and even the clear liquids at that point, we always want to make sure that they start on an IV PPI twice a day, and then they can transition to an oral PPI twice a day prior to discharge. All right, so outpatient management. So just like your POP patients, POEM patients definitely come back as outpatient. So usually as outpatient, if they're tolerating full liquids and maintaining their medication use, we see them at least 1 to 2 weeks after the procedure to make sure that their swallowing is okay. Each subsequent follow-up happens, and we also determine and see how their symptoms are. We use the Eckardt score, which is the grading score for symptoms of achalasia. It's based on 4 different aspects: weight loss, difficulty in swallowing, retrosternal pain, and regurgitation. It's a score based on 0 to 3 of each of those categories. And depending on if they're having no reflux or no weight loss, maybe occasional symptoms, daily symptoms, or even anything after meals, the score depends on those areas. So we always use the score to determine and see if the patient has improved from the procedure. So at the first follow-up, if there's any improvement in difficulties of swallowing, painful swallowing, regurgitation, all these symptoms of achalasia, we can advance them to a soft diet, which again may include like soft fruits like bananas, avocados, any like sort of soft mushy type of food like mashed potatoes, even oatmeal, cereals, anything like that. We also want to make sure we reiterate that they have to be on a proton pump inhibitor for 6 months post-procedure. And this proton pump inhibitor is at least your max dose of 40 milligrams twice a day. If patients continue to have worsening dysphagia or even worsening symptoms of achalasia, such as regurgitation, aspiration, choking, we make sure that they stay on a full liquid diet or even bring them back down to a clear liquid diet. And also we want to make sure we obtain a repeat barium swallow or a repeat imaging study to make sure that there's no other complications from this procedure. Even though we see them once after this follow-up, we want to continuously see them maybe even monthly or every couple of months. So they do have subsequent outpatient follow-ups. And we also set them up for an outpatient endoscopy at least 4 to 6 months after a POEM to assess the site. So I do want to go through a quick case here on a POEM patient I recently saw. So an 89-year-old female with a history of anxiety, hypertension, hyperlipidemia, arthritis, and GERD presented for evaluation of progressive dysphagia to solids and liquids. She had an EGD and manometry in 2014 that actually confirmed type 2 achalasia. She also had some prior therapies done, which included EGD with Botox, which initially she had good effect with, and she was asymptomatic for a while. However, she started to have these symptoms again, and in addition to the difficulty of swallowing that she had, she was having this nighttime regurgitation and also a 10-pound weight loss. During this visit and during this evaluation, she noted to have a food impaction, or at least a recent food impaction with solid foods, in which she had to undergo an urgent endoscopy to disimpact the food. And this occurred a couple of weeks prior to her outpatient evaluation. So again, her workup included the endoscopy and manometry in 2014, which revealed achalasia, type 2 achalasia. She also had a timed barium swallow prior to considering a procedure for her, which revealed persistent smooth narrowing of the GEJ and thickened esophageal folds. So through this all, she actually underwent a POEM procedure. So she was able to have this discussion with her family, and pending what her family discussed with her, she was able to go through the POEM. She was admitted overnight for post-procedure monitoring. Her barium swallow post-procedure showed no evidence of a leak, and she tolerated a clear liquid diet and was discharged on a full liquid diet along with PPI use, which we reiterated during her pre-workup and during her discharge. So she had some outpatient follow-up. So her first outpatient follow-up was 2 weeks post-procedure. She felt well. She had no fevers, no difficulty in swallowing, no painful swallowing, and no heartburn or regurgitation. She was actually very anxious to advance her diet to a soft solid diet. So she tolerated the full liquid. We advanced her to a soft solid diet. However, 3 weeks post-procedure, she complained of belching, noted limiting her diet after being advanced to soft solids, which could have contributed to her symptoms, but she started to have a couple of symptoms in the interim. Then 1 month post-procedure, she complained of nausea, but did not have vomiting. She also was taking Zofran at the time, but didn't feel like she had any improvement with the nausea, even though she advanced her diet. So what happened? Why did this patient have symptoms all of a sudden, even though she was feeling well? So nausea and belching are actually common post-POEM symptoms that can be managed by antiemetics and continued anti-reflux therapy. In this case, this patient was very fearful of advancing her diet due to her prior food impaction that occurred months before the POEM. So due to this, she was already limiting her oral intake while advancing her diet and not really sort of mentally being there when she was actually eating her foods and eating her soft solids. So after that visit at the 1 month post-procedure check, we went through her diet in depth, and we went through how to manage her diet and how to eat her foods. So 2 months post-procedure, she noted to have no nausea, no difficulties in swallowing, no heartburn or regurgitation, and she was actually able to incorporate more solids into her diet with no worsening symptoms. So with that being said, I want to actually go through some common symptoms for post-POEM patients and some even symptoms that you can see in post-POP. Most common in POEM patients are chest spasms. They can often occur post-procedurally and most likely are due to healing. In this case, we tend to use antispasmodics such as Levsin to treat these. Nausea is also common for patients in POP and POEM procedures. And along with that, some heartburn and regurgitation. And heartburn and regurgitation is actually more common in POEM patients, which is why it's very important that we make sure that they maintain on a PPI twice a day for at least 6 months. Bloating is also something that is very common for patients too, and can also be seen in post-POP patients as well. And it's something that we can also manage very well. There are some alarm symptoms that I actually want patients to be aware about and at least providers to be aware about. So fevers. Fever is very concerning for an aspiration, leak, or abscess. So we always want to work that up with labs such as a CBC and even imaging with a chest x-ray or even a CT chest. Chest pain, hematemesis, or even melena are very concerning for bleeding, especially when the scope is being tunneled through. So we always want to make sure that we work it up with a CT. And if it's very urgent, the patient should have an endoscopy to check what's going on with that area. Abdominal distension or even significant abdominal distension is concerning for a perforation post-procedure. And we always want to work that up with the CT chest to make sure that the patient is well aware of what's going on and that they're also managed very well. So I just want to go through some clinical pearls here with both procedures that we talked about and even their diagnoses as to why we do it. So gastroparesis in the POP procedure. It is very important that we know who to select for these type of procedures. Again, if they have a history of ulcers, surgeries, if they're on narcotics, we want to be careful in regards to patients who undergo these type of procedures. Patient expectations are also just as important. We want to make sure we reinforce what they should expect and also manage their diet, because again, it's going to be and often on managing of their diet. Again, POP does not cure gastroparesis. It's only used to help improve the patient's symptoms. So they should be on additional medication, continued therapy, whether it's their primary GI or another GI specialist. Achalasia and the Pullman procedure. You always want to make sure that you reinforce slow advancement of the diet and long-term PPI use. You always want to make sure you also avoid vomiting in the first 2 to 4 weeks post-procedure. Again, where that treatment is occurring, you want to make sure there's no inflammation within that area. Using antiemetics and following an anti-reflux diet are very important for these patients. And these patients may have food fear after and post-procedure. So again, these subsequent follow-ups are very important too. Here are my references. And before I even end this, I do want to acknowledge Dr. Kumar Krishnan, who I actually work very closely with and seeing POP and POLD patients, and has actually taught me so much about this. Thank you.